Good morning and welcome to our 5th event in the series. Share personal welcome. I think I just did that. Housekeeping. Presentation slides from today's event will be available from each PPS. Seems like we should have collaborated a bit more on that one. There's a map of the venue in your folder. I'm sure you found it. You find the location of lunch, breakout sessions, rooms. You will be receiving evaluations electronically tomorrow morning. How advanced of us. Please take a moment to complete. It'll help us prepare for the final session in March 2020. And I don't know if anybody's checked, but that might not be the final session because DISRIP might live on. Wouldn't that be exciting? At the end of the event, please drop your magnetic name tags in the baskets. Don't bring them home because then they'll just contribute to the landfill problem. And now is the fun part. Introducing our keynote speaker. Mark McKinney. I have known Mark for a better part of a decade, I think. And Mark is the CEO of the infrastructure that connects us all to each other. As the CEO of Hixny, Mark and his team are focused on advancing the secure electronic exchange of health information to improve quality of care, lower cost, and improve outcomes. Sounds like value-based care to me. Prior to joining Hixny, Mark served in many health care product development roles, focused on the use of data for real-time prediction and population health analytics for pharmacy benefit managers and software development companies. So welcome, Mark, and thanks for coming, everybody.
Good morning. Oh, I like this. So yesterday I was kind of starting to get ready for my presentation, and I decided to procrastinate a little bit, and I started reading some news articles, healthcare news articles, and one came across. It was that United Healthcare had announced that they had done a study, and if the entire healthcare system performs as well as their top providers in their value-based care program, the system can save $21 billion a year, right? So great news, value-based care is going to work according to United. The challenge, though, as I started to think about it a little bit, and the reason I kind of bring it up today is because it's very difficult to make the entire healthcare system look like the top performing providers in one single network. Right now, what they were talking about is the fact that they had this group of providers who had high quality scores. So they had providers who were really making sure that they were keeping people healthy and doing the things that Jacob really talked about a few minutes ago. But the reality is, to do that is easy for groups of folks, but the reality is that populations of patients have different characteristics, right? Some are sicker than others, some are healthier than others, some have different social determinants than others, right? Different things that make it difficult to manage that population. And so in order to be able to get the whole system up to the point where where these top performers are, we have to have data and we have to have information to be able to understand and stratify what these populations look like. And so when we talk about value-based care, Jacob said that, it's a 3-letter word. In health information technology, which is what Hixny does, we kind of prescribe to the PUMA method, which is please use more acronyms. And so during the day or during this talk, I'm going to throw a lot of them at you. So I apologize as we do this, and hopefully I'll explain them as we go. But I thought, when I talk about value-based care, I think of it really in terms of how do we keep a population healthy? So I'll talk about it in terms of population health, but honestly, in my mind, they're interchangeable. But I thought a good place to start with is with a picture. And in a sense, what does population health look like? And so, to me, I think it looks like the New York City subway map, right? And the reason is because just like in the subway map, right, there's lots of ways to get from point A to point B. we can take different trains, we can take express trains, we can take local trains. Sometimes we have to switch from one train to another to get where we're going. The system connects to other systems along the way, to the Long Island Railroad, Amtrak, and so on and so forth. And as population care managers, population health managers, care navigators, physicians, it's very important, right? We've got patients getting on and off all these trains, and it's very important if we think of these trains like their disease progression or their health progression in terms of where are they and where are they at. And we need to have information about whether the trains are on time, which direction they're going. Are they going uptown or downtown, making sure people are progressing at the rate and they get to the station that we expect them to get to. And so, to me, it's very important to kind of keep that picture in mind as we think about that, because in order to manage a system like the New York subway system, we need a lot of data, right? We need to know where the trains are, we need to know who's driving them, how fast they're going, so on and so forth. And so when you have lots of data, right, it can be overwhelming. And so I have this quote from Dr. Ritsema, who many of you probably know as the medical director of the Adirondack ACO, or as the senior vice president of quality information at CVPH. He's also the Hixny vice chair of the board. And he summed it up really simply to me once. He said, just tell me what it is that I need to know that I don't, right? And I look at that and I think to myself, well, that's great, but that's really oversimplifying things, because, well, I don't know what it is you know, right? And I now need to know what it is about your population that they need, and then I got to figure out what it is you need to know that they don't, right? So we need data to do that. We need systems to be able to do that. And so it's, that's something that's always kind of stuck with me. And so here's a diagram that kind of shows you a little bit about why that's so hard, right? This is data that's a couple of years old, but if I pulled the data today, the numbers would just be bigger, but the trends would still be the same. These are some hospitals in our region. They're kind of laid out geographically, so you could probably guess a little bit about who's who. But what this shows you is the number of patients who have records in different facilities, in different places, according to our systems. And so some of these hospitals, community-based hospitals, have hours driving time in between them, yet they have thousands of patients who have records in these facilities. And so what happens if you're treating a patient in one of these facilities, you need to have the data from all of these facilities in one location in order to be able to treat the patients effectively. We did a study of an emergency room about 2 years ago, and we compared what was in the emergency room's electronic medical record or electronic health record with what we knew about the patient inside of Hixny's system. And what we found is that about in 1 in every 5 cases, the electronic medical record was missing information that was important to the reason why the patient was there at that encounter. And so what that does is it prolongs the visit, right? It requires additional tests and services because we repeat things that we could have otherwise seen. And it keeps lengthens the time between a patient getting treatment and getting out the door. So bringing all that data, information together in one place is really significant. Most people think of Hixny, and Jacob described it as the underpinnings that bring the data together, and most people really kind of think of it primarily as clinical data, right? Data from hospitals and physicians and other healthcare providers. But the reality is there's probably 4 types of data that are really important in trying to manage a population, right? We've got clinical data, which I just described. We also have claims data, which many of you are working with, the Medicaid claims data through the PPSs. That data is a little bit different than claims data, clinical data in a variety of ways. It carries some clinical information in it. The data itself is often old and often can't be used to do some of the same things that you can do with clinical data, which can be in real time. And I'll talk a little bit more about those things in a few minutes. But then, of course, we've got social determinants of health data, information that can help us kind of upstream, as Jacob described, what is going on with a patient that might impact their ability to adhere to treatment or seek treatment in the first place. And then we've also got patient self-reported data. So Jacob held up his phone, right? The reality is we've got a number of providers out there, patients out there now, who have devices that can start to connect to the internet. It's called the Internet of Things, IoT, right? And so with that, there's the opportunity to do home monitoring of patients using some of these devices. And how does that data and that information come back into the system, and how can that be used to monitor patients' health when they're not in front of a provider? And so I'll talk more about each of these in a minute, but I'm going to start with clinical data and say that, obviously it comes from the electronic medical records, electronic health records of primary care providers and specialists and hospitals and the organizations you see listed there, right? We can use it for treatment, so obviously that's information that can be used in an emergency room or used in a physician's office. It can be used by a care coordinator to make sure a patient is on the right train, moving in the direction that we want them to move in terms of their health. We can use it to measure quality. So we can use that, for example, to look at a population of patients and say what percentage of that patients have had a certain test or service, and we can use that then to compare how a population is performing relative to benchmarks of different types. And we can use it for clinical risk identification. So we can use it to be able to identify patients and determine where there's opportunities to do something different. So for example, we can find a patient who may have had multiple high blood pressure readings at different locations on different days, who has no diagnosis of hypertension. We know that's a patient that might be at risk of hypertension. We can find a patient of future cardiovascular complications. We can find patients who are at risk of diabetes, who have certain markers in their data that would indicate that they could be pre-diabetic or diabetic. And we all know if we knew who those patients were, we would know what to do with them, right? And so when Wouter gave me that quote, he didn't say, tell me what to do with these patients. I already know what to do. What I need to know is who are the patients I need to work on, and so how do we find them? So clinical data can help us with some of that. There are some challenges with that. Interoperability, which is the systems that connect together, are still maturing. It's probably the polite way to say there's still a lot of work to be done. So we're fortunate in our region that Hixny has been able to connect these organizations together, but there are still, without question, some missing data. There are some challenges with content and quality. So the data is only as good as what gets recorded into the electronic health record in the first place. And so when that information isn't recorded the right way, or recorded a little bit differently than what the next system is expecting it to look like, the whole system breaks. And so there's still a lot of work to do to kind of smooth that data and make it a little bit more available and movable around the community. So let's talk a little bit about Hixny. So just in case there's somebody here who doesn't know who we are, what we do, we've actually been doing this for about 20 years. We now serve the region that you see there in blue, so all of western Vermont as well as eastern New York. In that region, there's about 44 hospitals that we have connected. It says here that we got 2,183 outpatient physicians. That's really just in the capital region to the northern border. So if you actually look at the broader region, there's about 4,000 physicians that we have connected or participating with Hixny. That equates to ultimately 267 behavioral health organizations, 75 nursing homes, 37 home health organizations, and 16 public health departments, when that's 15 county health departments as well as the New York State Department of Health, who are all using or sharing information in different ways so that that information can be carried to all of you where it needs to be used. And through that network, we have about 5 million patients in there. We're delivering 5 million lab results a month. And we're also about 140,000 unique patients' records are accessed every single month inside our system. So when I looked at this, when we started about in 2011 is when Hixny really started exchanging information, we were doing 52 records a month. So we've come a long way, but the reality is even 140,000 is a small percentage of the number of visits and information that should probably be exchanged on a regular basis. So there's still a lot more work to do. But just like the New York City subway system is connected to other systems, so you can get on a New York subway train and you can go to Penn Station and eventually get to California through Amtrak if that's what you wanted to do, information can be shared through Hixny kind of the same way. We can start with Hixny, which is called a qualified entity or a QE. Those QEs are tied together by something called the State Health Information Network or the SHINY. And so that gives anybody in our system the ability to access records really from anywhere in the state. And so just to kind of give you an idea of what that looks like, so we were doing 140,000 patients' records are being looked up every month. About 44% of those records actually return data from one of the other parts of the state. So, and the majority of that, more than half of that, comes from New York City and Syracuse are the primary places where that comes from, with the Bronx, Rochester, and Buffalo filling out the remainder. So I was kind of surprised when I saw this, that actually, almost in 1 out of every 2 records includes data that comes from outside the region. So patients are moving around. Now, the difference obviously is that Hixny is all payer as we share data, so that's not just Medicaid when we think about it from those standards. But in terms of where information is going and what's happening and how we're going to kind of close those gaps and get more information, there's a number of national networks which are evolving. These networks, 2 of them on the left, Commonwealth and Care Equality, are both vendor-led initiatives. Commonwealth is Athena and Cerner, the 2 primary organizations involved in that. Care Equality is Epic. They're working together between the 2 of them. Some of you may actually, in fact, have access to some of these networks today. So you can go in and you can use Care Anywhere in Epic, and you can look up a record in any other Epic system anywhere else, right? And that's great. It's a great way. It works in your workflow. It's really nice. It's a great way to get information. They're working to solve some of the common standards. And ultimately, what they do is they make that data available. If you need it, you can go out and you can get it, right? But what it doesn't necessarily do in all cases is make that data available so that some system can evaluate it and figure out what it is you need that you don't have and be able to share it with you directly, right? So it doesn't necessarily always meet that sniff test that Dr. Rietzma put out there. So we also have eHealth Exchange, which evolved from something called the National Health Information Network, which was an attempt to create a federal a single network for sharing information. That's called NHIN, that primarily today is what exchanges the VA, DOD, and Social Security Administration data. And then there's also something called the PCDH, which Patient-Centered Data Home, which is developed by a group of HIEs together across the country who are sharing information, both push and pull, which is the ability to retrieve a record if you want it or have a record sent to you automatically. And Chic is actually connected to some of the organizations in New York as well. So there's a number of large vendor-led or initiatives that are trying to get to a national level. So we have a New York level. We can get data from New York, but then I know when we look at our data set, we need data from other places as well. That's why we're in Vermont, but we need a high percentage of data from Florida as well, because we have just a ton of people, that's where they live or visit frequently. So how are we going to get that? We're going to have to get that from one of these networks in the future. So, oops, must have hit that twice. So the federal government has kind of recognized this problem, and I suspect Jacob probably had a lot of input into this way back when. And there's something called the 21st Century Cures Act, which was actually passed during the Obama administration, which mandated that organizations exchange data without special effort. And the idea was, really to do a bunch of things. It addressed a bunch of things around availability of data for pharmaceutical testing and a whole bunch of other things. But in there was something that said we need to make data available and freely shared as the norm across the industry. The intent was to really kind of level the playing field. They also wanted to make sure that they could facilitate patient access. So there's a large push at the federal government level to say patients should have access to their own data, right? So as we think about how we're going to keep patients healthy, we have to include patients in that discussion. They have to be part of the care team. If they're not part of that care team, then so communication among yourselves is great. It helps coordinate things, but we have to have the patient involved in that communication as well. And so giving them access to data is a key component of that, but then even more importantly, giving them the ability to do a variety of other things like share their data directly with providers is an opportunity to do something that's a little bit more forthcoming. And so we obviously have to protect provider, patient privacy and security. And so that 21st Century Cures Act has really kind of spawned a couple of recent activities. One is called the Trusted Exchange framework and common agreement, which is essentially supposed to be a national online on-ramp to a single national network. So I just showed you 4 national networks, right? And so there's really now this 5th one, which is TEFCA, the idea that the federal government is going to create this voluntary network, much like what the National Health Information Network, that middle one that I showed you before was, where everybody's going to plug in one time and all of that data is going to be available and going to flow between them. In order to do that, they've got to get common agreements. They've got to standardize how data is going to flow between them. And they've actually defined new data sets and new data standards, which I'll talk about in a minute. And TEFCA was actually announced more than a year ago. It's gone through a series of community revisions or public comment periods and has been re-announced. And as part of that, they continue to make progress in trying to stand that network up. Both ONC, the Office for the National Coordinator for Health Information Technology, and CMS, which I think you all know, Center for Medicare and Medicaid Services, proposed new rules in the spring of this year around how information needed to flow. One of the big things they focused on was something called information blocking, which they recognize that vendors and providers may block access to information in a variety of different ways. They can do it with fees that they charge. They can do it with their inability to want to share certain information and to do other things. And so the federal government has recognized that in order to make data flow the way that it should, we've got to have rules around how data, around information blocking and making sure that there are some exceptions, right? So if we know that it's going to impact the patient's health or safety, there are reasons why we can block data. But by and large, we want data to flow. They also put in place some requirements for both health plans and hospitals, which I'll talk about in just a minute. But let me just, this thing's sensitive. Let me just tell you, so with the TEFCA, the exchange, they have 3 common goals, which I just described a minute ago. And like the Shiny, they have a number of exchange purposes. So, but what's interesting about the federal government, they go beyond what Shiny actually allows for. So while Shiny allows for the use of data for treatment and public health and for quality and for individual access, so patient access, TEFCA also recognizes the use for health plans and the idea of using it for benefit determination and utilization review. And so what this hopefully does is it helps to align either the way the Shiny starts to work in the future and give more use cases to more organizations to encourage more people to participate, or allows for data to flow a little bit more easily for a number of different purposes. But I mentioned that TEFCA also has a new provision as it relates to data and information inside the system. And so they have something called the U.S. Core for Interoperability, or USCDI. And what they've done is they've said, so if everybody's used to a CCD or a CDA, which is the way most data is exchanged from an EHR to Hixny or from Hixny if you're connecting directly to an EHR, what they've said is we're going to expand that capability. And they've proposed a series of new information. So each year they expect to look at new information and see what's readily available and determine what new elements we're going to add each year to the USCDI. But the proposal right now is to say that the existing exchange of information through the common clinical data set excludes things like clinician notes, right? Something that's tremendously important. My patient was just seen by a specialist. I need to really see a summary or progress of what's occurred. We've also identified some information around provenance. We need to know who actually recorded what data and where it came from, right? That's tremendously important for a number of reasons. We need better demographic information, and we need some information about pediatric vital signs. But they expect not only that this information is available to everybody who needs it, but they expect organizations collecting it are going to share it, because if they don't, that's information blocking. So things like notes have always been an area that have been sensitive to a lot of physicians. I don't want to share my notes. I don't want people to know, how I document things. And so putting pressure on folks to share that information, is really coming from the federal government in a variety of different ways. I mentioned that they made an announcement around information delivery or event notification. So in our region, we do about 150 or 175,000 event notifications a month. It's a pretty large number. So every time a patient goes to the hospital emergency department, if you sign up for it, one of your patients goes there, we'll push that information to you. So we'll tell you what it is that you don't know that you need to know. We'll tell you that your patient has just left the emergency department of the hospital. We'll push you the discharge summary automatically. The federal government has recognized that's a problem. So while we're doing that in our area, and a lot of folks are doing that in New York State, a lot of places around the country apparently aren't. So they've required that by January 2021, all hospitals will send that information to providers moving forward. Of course, in order for hospitals to send that information, they're going to have to know who it needs to go to, right? Which is not as easy as it sounds. And so certainly a lot of work to do in a lot of places, but from our perspective, in our region, that's something that is not really likely to be a major impact. But what is going to change is that through some of the announcements from CMS, payers are now required to be involved. And so by 2020, I forget what the date is, by July 2020, health plans are going to need to exchange their claims data as well with other organizations moving forward. And you can see here what the list of information that they expect, that the federal government expects is going to be shared. And you can see here that, if you're a Medicare Advantage, Medicaid, CHIP, or qualified health plan, so if you're in the exchange of any kind, you're going to have to share that information. You're going to have to share that with other health plans for up to 5 years after the patient leaves your organization. So the federal government has heard that we have information and data in a lot of places, and we need to bring it all together and make it mobile in a lot of different ways. And so let's talk briefly about claims data. So Hixny, in addition to clinical data, has put a lot of emphasis on being able to start to bring in claims data. We've been approved to receive the Medicaid claims data from New York State. So we should be getting that into our systems any day. And because of the certifications that we've received from New York State, we're actually able to share that information out with any of the users of our system, so they'll be able to access that data. So claims data is important because it helps fill in gaps that exist in clinical data. So sometimes we just don't capture it because the provider still does it on paper, it's an EHR that can't connect. So a claim can fill in that information. But there are two types of claims data. There's both pre-adjudicated claims and there is post-adjudicated claims. And so Hixney's also getting pre-adjudicated claims from a number of the providers in our region where we're taking that data in and we're using that to help, in one case with one PPS, to use that to do some of the measurements that are necessary, because we can find data that's in the pre-adjudicated claims that we can't find in the post-adjudicated claims quickly enough. So everybody who's worked with the Medicaid claims data knows it's got a 6-month lag associated with it. So it takes a long time for that data to be useful and valuable, and then even when we get it 6 months later, it's still missing data, and it takes a lot longer for that data to accumulate completely. But pre-adjudicated claims come really almost in real time, and we can bring that data in, and they're valuable. Claims in general are valuable because they give us a bunch of information we wouldn't get. Not only fill in clinical data, but they also tell us, and they rank diagnosis information, for example. So everybody's heard about primary diagnosis and secondary diagnosis. That's not a thing in an electronic health record, right? That's a thing in a claim. It's something that the insurance system created in order to determine how best to what amount of money to assign to that claim when they pay it. At the same time, claims also gives us both medical information. We think about getting data from hospitals or physicians, but we also can get data from PBMs and from pharmacies, where we can use that information to do a variety of things. So when we have clinical and claims data together, we can start to look at doing what's called adherence. So we can calculate a possession ratio. We can determine, for example, that a patient has X days supply of medication on hand, and we can then determine who was responsible or how it happened that the patient doesn't have a certain medication. So in the clinical data, for example, we have the order. We know if a doctor ordered a prescription. With the claims data, we know whether the patient picked it up or not, and we know how often the patient picks it up. So together with that information, we can provide new information that becomes valuable to organizations who are trying to determine and make sure people are on the right medications moving forward. The challenge with claims data is there's still a lot of sensitivity to the business arrangements that exist inside them, what the fee schedule looks like for one doctor or another. I'm not going to spend any time talking about this because this, this is important stuff, but it's a whole other conversation. Social determinants, as Jacob said, and we talked about, gives you the ability to identify the underlying conditions associated with a patient care. Bringing that information together with the other data is valuable because it can help explain why a patient may not be picking up their medication because they can't afford it or they don't have transportation to the pharmacy in order to get it, right? And so the challenge with it, of course, is while it can move across some systems, it still requires better definition and a lot more opportunity to integrate that data a little bit better with other data sources. And I briefly mentioned patient self-reported data, the ability to monitor patients through devices like blood pressure monitors or Bluetooth scales and so on and so forth. We can use it again to fill in gaps in between. So if a patient is monitoring their blood pressure at home and there's a spike in the blood pressure, we as a physician or a care manager could see that and determine that we need to bring them in for a visit. And so we keep them out of the office or out of the hospital until the point at which something happens that we need to know about, and then we're notified about it and we can do something with it. The challenge with that is collecting that data is not always reliable. So for example, Hixny's been working to collect patient self-reported data. You can go, if you have access to our patient portal, you can go in there and you can submit your blood pressures and other values. But in order to make that meaningful to a provider, we actually have to go and ask the patient to submit it, to take their blood pressure at least 3 times during the day, then take the average of that blood pressure and say that was their blood pressure during the day, because when a patient takes their blood pressure, it's not as reliable than when a physician or a healthcare provider takes it. It also creates a lot of extra noise. Do we really want to know what the patient's weight was this morning, right, or anything else? Probably not, but we might want to know when an exception occurs, right? We certainly don't want to know all their Fitbit data, except, of course, if we're trying to monitor a patient, make sure that they're moving and following the advice that we have. So the problem is we're going to get a lot of data, and most of it is just going to be noise, but there is valuable information scattered inside that noise a little bit. So ultimately, you have these 4 types of data, and we can kind of think of it in terms of, how do we create some opportunity? So if you think about having Hixny as an all-payer data repository, right, where we've got claims and clinical, and in the future, a larger volume of social determinants, and maybe using patient self-reported data, and we can filter it, and we can sort it, and we can figure out what you know, and we can figure out what it is you need to know, right? We can use each individual data source to be able to find patients in the population that are relevant to what you're doing, right? But then we also can use the combination of that data, and that's where the power really comes in. So not only can we can use the claims data, for example, to identify the illness burden of a population and quantify how sick or healthy somebody is, right? We can use the information to stratify that with information about some of their clinical information. Maybe, for example, their blood pressure is really high, but they're already on certain medications or other things that would be meaningful, and therefore there's really no additional intervention we can take at a certain time. We can also use that data for public health research, public health and research. So we can use that for comparative effectiveness research or a variety of other things. But the other thing that it really gives us the ability to do is to start to look at benchmarks. Start to get the idea of being able to identify and say, well, we're looking at a quality benchmark or a clinical benchmark or some type of cost benchmark in the future. And what we want to know is, well, here's my number. How do I compare against others in my region? How do I compare against other types of providers like me? How do I compare to others who are treating a population similar to the population that I'm treating? And so this very busy slide kind of talks a little bit about where Hixny is at in terms of kind of a 5-year plan in terms of how we get some of this information together. And so you can see we're at a point now where we're using the clinical data to do quality reporting, so we're able to start to identify patients who might need a mammogram who meet certain characteristics. We can report what your rate of breast cancer screening looks like as a provider. Or as some population of patients. We can use it to also target and pinpoint individual patients who might need the tester service who don't have it. We have done a variety of other things to make data a little bit more available. As I mentioned before, we're going to get Medicaid claims data shortly. We just launched a project now to allow patients to consent. So if you're using Hixny, you know one of the challenges with Hixny is the fact that we have the same privacy rights for patients, and in New York State, you're required to get a written affirmative consent from a patient in order to view the records that we have available. So most practices, that's really not a problem because you're already getting a stack of papers with one more piece of paper to sign. But a lot of organizations like PPSs have patients who aren't in front of them. And so how do we collect consent? Because that's what unlocks all of this information. So Hixny's launched something that actually collects consent via text message and email that we're testing with a health plan and one local specialty practice right now with a plan for a broader launch in the future. The idea is that patients can now just get a text message, go online, and they can say, yes, I would like the Alliance for Better Health to be able to see my information, and then they get access to, then the consent is given, or any of the PPSs. We're also working on something for a consumer-directed exchange, the ability to get data to community-based organizations. And there'll be more to come on that shortly. We're also, because the federal government is requiring everybody to shift to this US CDI, they're also requiring us to shift to something called Fast Healthcare Interoperability Resources, or FHIR. It's another term. And so the ability to exchange data is going to get a little bit easier. So we have all those national networks, the ability to get all this data, or have a standard way of getting at it moving forward with something called the FHIR API, or Application Programming Interface. So Hixny is working on both of those things currently, and with an expected release early next year. We've done a number of other things in terms of being able to identify patients. We're working on risk prediction, the ability to identify patients who are at risk for readmission within 30 days or death after discharge by looking at what's called a LACE score. And we're looking at a number of other things as you look a little further out. But the idea is to have a comprehensive view of everything that we have. But in order to do that, we have to have all of the information really arrayed in one place. But when we do, we can look at various benchmarks and we can start to see how it comes together. So let me show you, what that might look like. So this is actually real data from our systems. So if you look across the region and we look at hypertension prevalence, the more red you are, the higher your rate of hypertension is. I suspect that none of this is a surprise to anyone. The region average is 38.8 and the national average is 29. So it seems like our population in our region is actually sicker as it relates to hypertension, or it could be that we're just doing a better job at diagnosing it and finding it, and so we're above average because we're doing a better job of actually recording it. But this data can be updated in real time. We can use the same information to then measure not only what the prevalence of hypertension looks like, but whether the patients are in control or not. So, so this is what hypertension control looks like. So these are patients who have a blood pressure 140/90 who are considered to be in control. So they've had readings that were high, but they're now in control. So the regional average is 25.4. The national average is 48. So we seem to be doing really good. We have more hypertensives. We're doing a really good job of managing them, right? And so and we can look at diabetes prevalence. Same thing here. We're a little bit above the national average in that area. The difference here is that, and we're again, our undiagnosed diabetes rate is very low. It's almost zero, right, in terms of a national average of 4.3. So we're doing a really good job. Now, this is data that comes directly from all of those systems that are connected to Hixny and sharing information. Public health departments have access to this, and they can look at this really in real time as this information is coming in. But as we get more of that claims data and we get more information into the systems, we can refine what these things can do and how we can look at it, and they become better tools to manage the care for value-based care moving forward. So I'm going to stop there and see if anybody has any questions, because I've talked really fast. It's an exchange directed by consumers. So it would, if I was a patient somewhere and I had the ability to download my record, and I said I want to send my record wherever I want to send it, I could send it to the Times-Union, they could publish it on the front page of the paper if they wanted to do that, or just so happens maybe what I'd like to do with it is download it, and I'd like to send it to some community-based organization who couldn't otherwise access information, so that they can do some care of me that they otherwise couldn't do that. Okay.
Discussion about contacting like jails and prisons to get the information or medical information tonight, 'cause that seems to be a struggle as a community-based organization, you know, to get access to those records post-release.
Yes, I mean, the very short answer is yes. We have actually talked to the Department of Corrections in New York State. You know, obviously, in certain parts of our region, prisoners may outnumber patients in some areas, right? And so, so we have talked to them. They have some pilots that they're working through with some of the other regions in the state. And so, but because of the shiny, providers can get access to some of that information. So they're working on a pilot in Coxsackie right now. Any other questions? Way in the back? I believe so, yes. It should be all Medicaid. So it essentially should be whatever it is the PPSs would have access to. But then the intention is to expand what Hixny would have access to over what the PPSs gets, what's called a limited file, a Medicaid claims limited file. So there is some discussion about us being able to get access to a broader set of information over time.
Under the federal and state patients' Bill of Rights, patients have rights to their medical records. How, if at all, does Hixny help achieve that requirement?
So great question. So there's actually 4 requirements in the state health information and the Chinese policies and procedures in terms of how a patient can gain access. So they can gain access through a portal that the QE will put up. So Hixny has a portal. Somebody can go and sign up for that portal and gain access to their records that way. They can download it. They can do whatever they want with that information. They can use it to direct it to some other provider or email it to whomever they want, a caregiver, so on and so forth. They can also request it by paper from as well. Obviously not the preferred method for a variety of reasons. But so there are ways to do that moving forward. I went quickly through the kind of the roadmap slide, but Hixny is actually working on taking our patient portal and enabling the ability for it to integrate with other platforms that are out there. So Apple Health, for example, is a platform that, you know, you can just go on Apple Health and it'll show you which organizations have data that you can connect to and pull if you have an account. And so we're working on making the interface that would enable us to connect to hundreds of applications over time to be able to do that. The biggest challenge with giving patients access to data is validating that the patient is who they say they are. And so I didn't talk about it at all, but in the TEFCA requirements, there's actually a part about patient identity validation, which says that we have to have a way so that when Mark McKinney walks up and says, I'd like my data, to know who Mark McKinney is. And so right now for our patient portal, the way we can do that is certain organizations can go and they can identity proof the patient and give them an account. But that's not really practical for patients who just may want to go online and do that. And so we're actually working on something to what's called knowledge-based authentication, which would give a patient the ability to answer some questions and then therefore gain access to their record. And we're using that, a very small form of that today in that e-consent project that I talked about briefly. Go ahead.
When you look at this through the lens of behavioral health and tracking trend data on patient care results, will that mean standardizing assessments at admissions and discharges? What will that look like?
So, you know, so the behavioral health has been one of those areas where the problem has been that there hasn't been a lot of transmission of a lot of the things that people need. So for the last 2 years, Hixny has been involved in a project with the state to measure the effectiveness of disrupt by, they come and they do some medical records review, and I forget the name of the companies who do it, but they come and the state is hired, and they come and they say, for the PPSs in your region are working on these projects, we need this data, and then we're going to take and evaluate whether we've met some goals. And all the PPSs in our region have been focused on mental health and behavioral health issues, and they've asked us for some of the behavioral health assessments, and we go and we look in our systems, and there isn't a lot of it there. It's almost, I mean, literally, you probably count on one hand how many of them we can find. And it's because the standards, as you mentioned, are not really there. But the intention, you remember that USCDI, right? We're going to keep adding data elements. We're going to keep standardizing the way information is exchanged. And so behavioral health is going to have to be a huge part of that moving forward. And it's going to affect both what you collect and how you collect it, how your system stores it, and how your system has to transmit it. And so, it's an area where there needs to be a lot of development that there hasn't been currently.
Thank you.
Now, right now, our patients have to sign up for Hixny. Now, if we go into the government programs, are we going to have them re-sign up to exchange their data into that?
So, yeah, so the couple things there. So what we're asking, when your patient isn't signing up for Hixny, when you consent, when a patient consents, what they're consenting to is for you to be able to view their data. So their data is already in Hixny, right? Because it's all connected. But in order to protect the privacy of the patient, we say no data can be viewed unless the patient gives us a signature on a piece of paper or electronically. And so that's what that is. So the federal network, the TEFCA network, is envisioning consent a little bit differently. They're trying to do it with an opt-out approach where everybody's going to be notified that everybody's going to be able to view your data unless you opt out and tell us that you can't. Now, when you do that, some information is left behind, right? So in Hixny, when you get to see Hixny, the data in Hixny, you get to see everything. You get to see mental health, behavioral health, as well as clinical data and anything that's in there. But when you have an opt-out approach, you're only going to get to see some of the data. So things that may be covered under SAMHSA or other rules, mental health and behavioral health data, substance abuse data, is not visible unless they still sign. And that would probably still be true in a TEFCA network. So what you end up with is something as a kind of a hybrid. You opt out from most things for 80% of the data, but then there's still 20% of the data where you have to opt in or say, I want somebody to be able to see it. Any question?
Hi, I'm Lori Levasser from Hometown Health in Schenectady, New York. And I just have a question regarding any collaboration in the future with AARP. We've identified that we have a large population of patients that go to Florida, maybe in the winter, then come back in the summer, and being able to share information. And many of those patients are associated with AARP programs. So I was just wondering if Hixny had anything in the future associated with collaborating with AARP.
We don't have anything currently, but I just did turn 50 last year, so I've been getting those things in the mail, so maybe I'll pay more attention to them moving forward, but not currently. But we would assume that eventually something like AARP would plug into a national network, and then we'd be able to get it through that method. Okay, one last question.
Has there been work on trying to be able to provide more limited data sets to organizations that it might not be appropriate that they receive everything? We have compliance issues that can be resolved with some Hixny data, but we have no interest in clinical data in that sense.
So let me see if I can summarize that question. So you're asking, is it possible to filter the content that goes to organizations?
Not even filter, like we would never want the opportunity to see it. So like we'd want to make sure there wasn't a duplication of service, but I should never be able to see what someone's diagnosis is or something.
Right. So there are opportunities and capabilities for us to be able to, restrict the data sets to limited data sets that get exchanged or viewed by certain organizations. So yes, that's possible. The challenge is for us to set up that as a relatively manual process because what you want may be different than what she's going to want or what I want. And so, but those capabilities do exist. I think if the community or the organizations could come together and say, here is a standard set of information that we know will meet all of our needs, we could define what that would be, and then we could say, this is you're going to get this individual payload. Okay. Well, thank you everybody for your time and listening to me.